For the Daily Princetonian, I'm Mark Dodici, and with us today is a lecturer in the Woodrow Wilson School, Professor Heather Howard. Professor Howard, thanks so much for joining us.
Thanks, Mark.
So, first off, what do you do at the university?
A couple things. One, I run a program that is funded by the Robert Wood Johnson Foundation, and we work with states, helping them implement health reforms. And then I also teach and advise students. I'm teaching an undergraduate seminar this semester on health reform in the U.S. and a graduate seminar on state and local health policy.
Okay, so logistically, so you teach two classes. So logistically, how have those changed, and what difficulties have you found moving a sort of discussion-based class online?
So let me start. I also advise several senior theses, and I've been continuing to meet weekly with my advisees via Zoom, and that's gone pretty well. That transition has been pretty smooth. For my undergraduate seminar on health reform, we've moved to Zoom, and that also has gone pretty smoothly, I think. I hope. It's 25 students, but I've been making use of the breakout function. The breakout groups, and that seems to work pretty well. So I've got 25 students, and I break them into 5 groups, and I can say, go meet for 20 minutes on this issue, and then come back in and report in on your deliberations. So what I found, 3 hours is long for it's long for any class in person, but it's that much sort of harder on Zoom. So breaking it up by having those breakout groups, I think has helped to keep it more interactive. And I also find that the raise hand function works well, that students have really participated, and I've been able to sort of see who's got a hand raised and get to people. So it's been more conversational. I had been afraid that we wouldn't be able to keep it interactive, but it's worked well.
That's great to hear. So with students spread around the world, you said it's a very interactive class, but so I assume you have some students in different time zones. So what sort of adjustments have you had to make to sort of ensure that everyone has an equal experience in your course?
So a couple. One, the class normally meets on Tuesday afternoon, and so we've been meeting at the same time, and that hasn't been a problem because it's in the afternoon for the people on the West Coast. So we haven't had to change the time zone. That's been fine, and I think people prefer that we keep I've been trying to keep things as regular as possible, having class at the same time. I have my office hours at the same time, but they're now by Zoom, so people can just drop in. And that's worked well, too. People sort of hang out in a waiting room, and if I have more than one person, I can message them and then move them into the main room and say, hey, I'm with the student, I'll get with you in a minute, and then I can move them in. So I can see, students, take students that way in office hours.
That's great. So obviously studying health policy, that's a pretty important topic at the moment. So have you made any changes to your curriculum for the rest of the semester?
I have. I mean, I've incorporated the COVID-19 work directly in, because how can you not? And it's obviously so timely, and it's a lens through which we are learning a lot about the dysfunctionality of our healthcare system. So one thing I've done is I devoted a whole class to readings about COVID-19 and all the health policy challenges. So we were debating, for example, how do you make testing and treatment available to people who lack health insurance? We did readings and discussions about the federal stimulus bills. And one of the breakout groups that questions that I assigned the class was trying to envision a public health New Deal. What might be the kind of public health response that might come out of this, like the New Deal in the Depression? So sort of how would we reimagine our healthcare system now that such a bright light has been shown on the cracks in our system? And then, so that one whole class was on that. And then subsequent to that, every class we start by asking, well, first I ask how they are. And some people have been directly affected. They may have family members. who have been tested. With many of the students are pre-med and have family members who are healthcare providers. So they're talking about what's happening to their family members. They themselves may be going to med school, thinking about what this means for their career. So we spend some of class thinking through those issues and sharing those and reflecting on the readings. Every week something. A couple weeks ago, another breakout question was I asked the students to envision that they were advising the governor of Florida on his authorities in response to the pandemic, and would they advise him to close the beaches? What would they advise him? And so then subsequent weeks we've been revisiting, well, what has Florida done? And has the governor done what they would have recommended? It's been interesting to sort of reflect on what they might have advised versus what's happening across the country.
So, have the governors generally been doing what your students would recommend, or how's that going?
No. What we're seeing is a real varying responses across the country, and this is partly what's unique about the U.S. healthcare system is that we have a lot of variation across the country. We have this federated system whereby a lot of and because of a lack of clear federal leadership, we're seeing states respond very differently. So the New Jersey and New York governors and California governors and Ohio, I would point to those, responded very quickly and very strongly. And then you've seen in other parts of the countries, the governors move more slowly to recognize the threat of the pandemic. And so we've been talking about that, and how do you, and some of that is a result of the different political cultures in those states. How much governors may feel like that the public will not be willing to accept extreme measures in a way that may be a reflection of that political culture. Unfortunately, I think it's also a reflection of, a failure to recognize how quickly the epidemic was spreading across the country. And so, but we've been able to see that in real time, how states are reacting. And of course, we've got students in some of these states. So I may ask a student who's in Texas, how do you see what's been happening in Texas is that the reaction has really varied by county. So some of the students are seeing a different reaction because the governor hasn't yet had a statewide stay-at-home order, but it's varied by county. So we've been able to explore that in real time.
Interesting. So one thing I have heard on the internet is the virus doesn't discriminate. You're a health policy expert. Do you think that's true?
No. I think from a medical perspective, no, it doesn't discriminate. We're learning more and more. People early on thought that young people were immune to it, which has turned out not to be true. But I think that's the wrong lesson to take away, that anybody can get it. Because what we're seeing is that while anyone can get the virus, it's having a disproportionate impact in terms of the severity of the illness and the deaths. And just this week, we're starting to see really, really sobering data from some American cities that, in particular, African Americans are dying at much higher rates because of COVID. And I think what that's uncovering are two things. One, the inequities in our healthcare system and the disparities that African Americans face in our system, and the systemic racism that causes a greater disease burden, which makes them more vulnerable if they do develop the disease. I think the second thing that we're going to be learning more about over time is that certain populations, definitely depending on their socioeconomic status, have been less able to practice the social distancing that public health has been recommending. If people need to go to work and need to take the subway to get to work, they're more at risk. So there's the general health status of populations that may make them more susceptible to a more serious outcome. And then there's also the way this pandemic is playing out, and in terms of some people's, the privilege that some people have to be able to socially distance in a way that others don't. So it has not been the great equalizer in a way that some people thought it would be. And that's something that we're going to be talking about next week in my class, because this data has now, states are starting to report, cities and states. New York just today started reporting their caseload data by race and ethnicity. And so we're going to have more data to be able to dig into to try and understand sort of this tragedy as it's unfolding.
So, all of that in mind, as a professor in the Woodrow Wilson School, what advice would you give to policymakers in the U.S. and around the world, and everyone affected at this time, really?
Well, I think one, it's that it seems like the measures we're taking on social distancing are working, but I am very worried that people will see we're beginning to see some promising news about reports of some flattening of the curve, and I'm worried people are going to draw the wrong lesson from that, and will maybe relent on some of those measures too soon. So I think it's that we need to commit to these measures for some time now, and we need to continue to have a data-driven response and not react to early good news and not pull back. So that's a big one. I think the second is that I really hope that going forward we can have more of a national response, so that states aren't competing with each other for supplies, so that or that states, we don't have this patchwork of state responses that jeopardizes all of us. And finally, I hope when we come out on the other end of the tunnel that we're going to be ready to learn from this and to think and to really implement some of the lessons we've been learning about how we need, it's in everyone's interest to have a stronger safety net, how our own health is affected by our neighbors. So the lack of universal health insurance is undermining the ability to respond. So I think there's going to be some clear lessons about how we can improve our public health system and expand access to health care that I hope we will be willing to learn when the crisis is over.
Yeah, so you talk about when the crisis is over. When do you think America can expect that?
I fear not for some time, because I think experts have been saying that we need several things to happen at once in order to let up, and that's going to be, we're going to need to see a sustained drop in cases. We're also going to need the ability to test and trace and isolate the people who have the virus, and we just don't have that testing capability. So we need both to see progress in our case progression, but we also need to know that we have those public health tools in place to be able to, so that we can tell who has had the virus, who may have developed immunity, so that maybe they can go back to work, and we can isolate new cases and trace contacts. And I fear we're not there yet.
That makes sense. And so lastly, bringing it back to Princeton a little bit, do you have any thoughts on the university's decision to give the pass-fail option for all classes, but not to make that program mandatory?
I think they were weighing a lot of different equities, and I know there were challenges in different departments depending on department requirements, and I think they made the best decision they could in a very difficult situation. I made my class mandatory pass-fail because I thought that was the most equitable thing to do for the students, because I know some students are going through very tough times and are in very challenging situations. But I know that not every class is like mine, and I think they were making the best decision they could.
Understood. Thank you. Well, Professor Howard, thank you so much for joining us.